So let's start with a question. Question is, a diffuse dorsal root ganglionopathy is commonly due to which one of the following causes. So the first, the main thing to know is what is a dorsal root ganglionopathy, and then you can kind of try to figure out what may be the cause of it. This is a complex question. It will not be an easy question even for a neurology resident. So this probably is one of the toughest questions you guys will have. So let's look at what is a ganglionopathy, and then we can come back and discuss these causes a little bit later on. I try to move. Okay. So this is the structure of a peripheral nerve, and we looked at it before. This is abbreviated one. So we have the spinal cord, we have the gray matter, and we have the white matter, and then there is a dorsal root where the information is coming in, which is sensory information, and there's a ventral root which is motor where the information is going out. And the dorsal root has a ganglion on it and has some cell bodies. And these cell bodies then give out nerves that come in. Some nerves will join in the dorsal root again with another nerve, cell body, connect with it. And then that will cross over and rise up as a anterolateral spinal tract. And some will ipsilaterally rise up, which will be the dorsal column. The dorsal root has the cell bodies for sensory input or sensory nerves, fibers, spinal thalamic tract and dorsal in the vibration proprioception dorsal. The ventral root does not have any nerve bodies. The nerve bodies are in the motor neuron in the anterior horn cells, and it's just axons coming out. These two roots then join to form kind of a common root that we think of as a root traditionally, nerve root, and then they will come out. They start giving out branches, and the branches intermix with each other to form a plexus, and then those plexus then give out the nerves from various parts of the segments of the plexus. So you can have a problem with the root itself, the main joint root, which is called radiculopathy. You can have problem with the plexus later on, which is plexopathy. You can have problem with this dorsal root ganglion, the cell bodies that are sitting here. And that is what is called a ganglionopathy, or we prefer to use word neuronopathy. Neuronopathy, there's an N here instead of neuropathy, neuronopathy. Ganglionopathy might be easier to remember for this dorsal root ganglia. You can have involvement of both the radical nerve roots and this neuron or later on, so it could be a radiculoneuropathy. You can have problem with the nerve roots itself, the dorsal or ventral root, usually dorsal root, which is called a radiculitis, usually polyradiculitis. You can have a neuropathy, which is the damage to the nerve, but you can have neuropathy that involves multiple different nerves, and that is called either a multifocal neuropathy or a mononeuritis multiplex. And then neuropathy itself then can have different variations. There could be neuropathy due to damage to axons on the nerves or the myelin, the demyelinating neuropathy I mentioned in the previous section. You can have problem with the motor nerves or the sensory nerve. So it will be motor neuropathy or a sensory neuropathy or mix. You can have problems with a small fiber or large fibers, and that's the distinction between sensory neuropathy. Motor are only in large fibers. So sensory neuropathy could be a large fiber sensory neuropathy or a small fiber sensory neuropathy. And then the motor neuropathy can be ascending neuropathy or descending, and that's the pattern of body involvement. That is the problem with weakness or motor problem starting in the feet, going up, or starting in the head and toe, head and neck, and going down. So radiculopathy versus a plexopathy. Radiculopathy we typically think of in a degenerative disc disease where there's herniation of the disc or inflammation or infection compressing on the nerve roots, right? So if I go back to the anatomy, I don't have that picture of the spinal cord, but here it could be a disc herniation as this tries to exit the foramina, and the disc can pinch the nerve root right there. You can have a radiculopathy. Usually, there is pain and sensory loss in the distribution of that nerve root, and it often involves a back pain or a neck pain along with it. And then there is usually partial weakness, but never a complete paralysis of a muscle because each muscle have multiple nerve roots supplying it. A single root is usually involved, although you can have multiple disc herniations involving 2 or 3 nerve roots. And typical abnormality that we look for is a loss of reflex. Most reflexes, although they have multiple nerve roots supplying them, they have one main nerve root supplying that reflex. So, for example, ankle reflex is L5 and S1, but mainly L5. And similarly, the knee reflex is L3, L4, but mainly L3 that is supplying the knee jerk. In contrast, a plexopathy is a disorder that is restricted to a whole limb with involvement of both motor, sensory, and reflex impairment, and is usually very painful, much more than a radicular pain, and can be seen with inflammation, rarely with diabetes, uh, often with trauma, and occasionally with tumors or neoplasm. And it will involve multiple nerve roots in a partial fashion. You can have a painless plexopathy that is uncommon and is classically seen with radiation-induced scarring. So here's a list of the problems that can cause a plexopathy and two common patterns of plexopathy. So one plexopathy that happens when there is a sudden stretch between neck and shoulder, where the head gets stretched in a certain way. The most classic example is a breech delivery, and that causes what is called an Erb's paralysis. There's a very peculiar position of the hand. The hand is pronated, adducted, pronated in the forearm. The wrist is flexed, the fingers flexed, and internally rotated. And you get a very peculiar position of Erb's paralysis that used to be called a Porter step position. The other pattern happens when the stretch is in the axilla. So between the arm and the body, the stretch is this way. That you suddenly went up like that, and there's a severe stretch that happened in the axilla. And that gives you what is called a clumps paralysis, where the arm is flexed at the elbow and flexed at the wrist. It's extended at the metacarpophalangeal joint and then flexed at the PIP, proximal interphalangeal and distal interphalangeal joint. They have like a claw hand, which is flexed and is in. So it's more like a spastic hand post-stroke, but the difference is the extension at the metacarpophalangeal joint. And that's another common birth injury when arm is yanked, or in a neonatal injury when the kid is yanked with the arm as they're crying and they're trying to walk and you suddenly yank, you can get that kind of an injury. The there is, in terms of neuropathy itself, there's difference between sensory and motor, large and small fiber. So I highlighted some of those things for this table. That if a large sensory fibers are involved, you have problems with vibration proprioception. With the small sensory fiber, the problem is more with temperature and pain. So anterolateral spinothalamic tract. And motor nerve fibers, if they're involved, then you see wasting. Muscles require continuous nerve input. If they lose that nerve input, then they start becoming wasted. And there will be hypotonia and there will be loss of reflexes. And autonomic nerves, when they're involved, which is not very common, usually it's separate from these nerves, then you will get loss of sweating and hypotension, urinary retention, or other problems. The other thing we look for in neuropathy is the pattern. Is it acute, meaning that onset to full blown within 4 weeks or less, usually 1 to 2 weeks? Subacute, between less than 3 months. Chronic, more than 3 months, typically 6 months or so. And chronic progressive, chronic non-progressive, relapsing and remitting, or monophasic. We also, for neuropathies, look for the pattern of involvement. Is it length dependent, meaning that the longest nerves are damaged first, and that's why it does not involve the hand until the nerve damage reaches the lower third of the leg, and then it starts involving. That's what we call the glove and stocking pattern. Or is it multifocal, or in a different patterns? Sometimes we call them multifocal neuropathies or mononeuritis multiplex. Here are some of the common causes for axonal versus demyelinating neuropathies. Demyelination, we looked at before. Schwann cells are peripheral myelin cells. Guillain-Barré is the main quintessential disease of an acute inflammatory demyelinating neuropathy, or AIDP. AIDP is a larger category, and most common cause of AIDP is Guillain-Barré, but other things can cause AIDP too. And that's why AIDP is an acute inflammatory demyelinating polyneuropathy, whether from caused by a para-infectious phenomenon or not. While a chronic inflammatory demyelinating neuropathy will be CIDP, which is again the most common form of demyelinating neuropathy. But Charcot-Marie-Tooth, or CMT, can be a demyelinating neuropathy. Some paraneoplastic syndromes, such as multiple myeloma, can give demyelinating neuropathies. And we don't see diphtheria very common, but there used to be a cause of demyelinating, usually a descending paralysis, in contrast to Guillain-Barré, which is an ascending paralysis. Usually Guillain-Barré is motor predominant. They are the motor fibers affected first, and has usually sensory sparing early on, but later on can have some sensory symptoms, but is an ascending paralysis. In contrast, something like polio Poliomyelitis is a descending paralysis. Botulism is a descending paralysis. Axonal neuropathies are the common ones. Those are the ones that you typically see where the nerve axons are damaged. Diabetes, the quintessential example, most common form of neuropathies, and a length-dependent mixed sensory motor axonal neuropathy, which is diabetes. But deposition diseases like amyloid, vascular diseases, vasculitis, paraneoplastic syndrome, vitamin deficiencies like B1, B12 deficiencies can cause axonal neuropathies and toxins and so on and so forth. So you see this is a much larger category. Demyelination is not very common. It's usually autoimmune, and occasionally hereditary. You see some patterns here. This is a distal symmetric polyneuropathy. This is the mononeuritis multiplex. In mononeuritis multiplex, usually the age of the neuropathy is different. Some come on early, they start healing, then the other one come on. In a multifocal neuropathy, the age is usually the same. They all come together. While in a mononeuritis multiplex, just one follows the other, follows the third, follows the fourth. Oh, and then one pattern is the ganglionopathy, which is a different kind of a pattern than a neuropathy, which is the dorsal root ganglia disease. That was the original question that we initially dealt with, and we'll go back to it. Here are some of the patterns. So this is less common form of neuropathies. This is a leprous neuropathy from leper's disease, which is a spirochetal infection. This is a Charcot joints of a Charcot-Marie-Tooth disease. Charcot joints are these kind of a high arched, abnormal with these toes, which look like the hooks where there is again extension part at the metacarpal, metatarsophalangeal, and flexion later on, kind of a feet, and they also turn in slightly. There is the painful neuropathy from poisonings, usually gives Mees line, which is an arrest of the nail growth, and then the nail growth starts back up, and that arrested area gives you a line. That's the Mees line. And then most interesting, although not very common, is a B12 deficiency. It can cause distal sensory neuropathy, but B12 can cause many things. And here's the strawberry tongue of B12 with pernicious anemia, but B12 can cause spinal cord pattern, transverse myelitis, can cause ganglionopathy, and so on and so forth. B12 is a great mimicker. So let's go back to the first question then. Then what will cause a ganglionopathy? B12 deficiency can cause a ganglionopathy, not very common. Diabetes classically causes axonal sensory motor polyneuropathy. Amyloidosis will cause an axonal sensory motor polyneuropathy. Deposition disease. Tanger's disease is extremely rare disease, not very often seen, doesn't cause much of a, again, is an axonal neuropathy, but not very commonly. Mainly rheumatological conditions like Sjogren syndrome will cause a dorsal root ganglion involvement, or ganglionopathy. And in ganglionopathy, you may see a distinction between sensory loss from a dorsal column versus central-lateral. So pain and temperature are usually involved less, vibration proprioception involved more, and the pattern is unusual where there may be distal sparing. Instead of distal disease, length-dependent disease, there may be distal sparing, and that Sjogren syndrome will cause a dorsal root, or any other rheumatological disorder will be often the cause of a ganglionopathy. And this is what I mean by distal sparing, that you may have a leg involvement around knee, but sparing of the ankles and below. And that is a classic sign that it's not a length-dependent neuropathy. Okay, next question, 35-year-old man who has a diabetes since childhood develops erectile dysfunction. So that's an autonomic dysfunction. He has absent deep reflexes at wrist and ankle. So that's a neuropathy. Loss of position vibration at the ankle. Again, length-dependent neuropathy, and no demonstrable anal or cremasteric reflex. Now that typically goes against neuropathy. That goes more for root involvement, either at the exit or within the spinal cord root involvement. What is most likely disturbance? What other disturbance unlikely to be present? So he has mostly sensory presentation. Babinski will be a more motor phenomena. Gastroparesis is again autonomic dysfunction. Bladder hypertonicity is an autonomic dysfunction, and hydrosis is an autonomic dysfunction. So if this is an autonomic disease, then it's most likely to have the other three, and less likely to have a Babinski sign, which is more of a motor phenomena or upper motor neuron dysfunction. And this is more of a neuropathy. Babinski is an upper motor neuron dysfunction, right? A corticospinal tract disease. This one, by the way, the loss of reflexes, anal and cremasteric reflexes. This is the dorsal nerve as they come out of the end of the spinal cord. Spinal cord ends at L2, disc between L2 and L3, top of the disc between L2 and L3. So L2 spinal cord finishes. but the nerves has to come out from L3, L4, L5, T1, S1. All those nerves that have to come out below, they have to travel in the spinal canal before they can exit. So there is a portion in the spinal canal when the nerve roots are traveling, but there is no spinal cord anymore. That's the distance between L2 to S1. And that area where there's a lot of nerve roots traveling is called cauda equina, where there is the horse tail, basically all these nerve roots coming out. So you can have a spinal canal disease, usually like a compression, or disc herniation, central disc herniation, or hematoma pus, that can get bunch of these nerves together, L4, L5, S1 together. And that can cause problems like loss of bladder tone control, loss of anal reflex or anal sphincter tone, and cremasteric reflex or things like that. Question 12. So after recovering from an overdose, a 31-year-old heroin addict has paresis of his right wrist. Paresis is weakness, partial weakness. Right wrist, thumb, and finger extensor muscles. Very peculiar weakness. So it's a wrist weakness, the wrist drop, thumb weakness, and finger extensor muscle weakness. So it's a kind of a dropped hand. All deep turn reflexes are normal except for the right brachioradialis deep turn reflex. So very specific root are involved that is affecting it, or nerve is involved, and not other reflexes. Where is the lesion? So lesion cannot be in cerebral hemisphere because the involvement of reflex is very specific, only brachioradialis. It cannot be spinal cord because the reflexes are depressed, and there is very specific peculiar weakness. And remember, in a single nerve root or spinal cord, you don't get one muscle weakness or one or two specific muscle weakness. You get a bunch of muscle weakness. So that leads us to a nerve mainly, that a nerve is involved that is giving such a very precise amount of weakness and a very specific reflex involvement. So it has to be a nerve, whichever the nerve you select, median, radial. The difference between median and radial nerve is that median is more of a grasp nerve and radial is more of an extensor nerve. So any wrist drop or extension drop will be radial, and any grasp weakness will be median. So carpal tunnel syndrome, the main complaint of patient in carpal tunnel is that they drop things out of their hand. So if they're holding something heavy, it slips out. That's a carpal tunnel, that's a median nerve. The radial nerve will be the hand drops, that the extension of the hand is gone, and that may cause problem with like handwriting, or opening bottles or cans or something like that because of a dropped hand. But usually grip is okay. 34-year-old male with chronic low back pain experienced an exacerbation while raking leaves. The low back pain that got worse. He has difficulty walking and pain that radiates from the low back down the left posterior thigh to the lateral ankle. So ankle, the outer side of ankle is typically S1 and the inner side is typically L5. Inner ankle is L5, outer ankle S1. Ankle reflex is L5, S1, L5 more than S1. And pain that goes all the way down to the ankle suggests more of a radicular pain, while a pain that stays in the back and goes down to the hip and not lower is typically a facet joint pain. So back pain can be from the joints between the vertebral bones. That's the facet joints. You can have a facet joint pain. You can have arthritis of the facet joints or the hip arthritis. And those back pains of hip bone or facet joint will typically not radiate below mid thigh. They will go down to the buttocks, they will go down to mid thigh, and that's it. A radicular pain typically goes on all the way down to the nerve or down to the ankle. So pain going down to the ankle, radiating down to the ankle is supportive of a radicular pain or radiculopathy. He has an area of hypalgesia along the left lateral foot, so outer foot, that goes more for an S1. And that means that the two options here are L4-5 and L5-S1. The L4-5 disc herniation will compress L5 nerve roots. L5-S1 will likely compress the S1 nerve root. So between the two, right now, I will favor L5-S1 involvement. Cauda equina is unlikely because there is no bladder problem. There is no analgesia around the anal area. The femoral nerve infarction is an unlikely because the pain is starting from the back and going down. Sciatic nerve infarction is possible, but we are not seeing the foot drop that we'll see with the sciatic nerve involvement and weakness of the ankle or instability. So it leaves one of the two disc herniations And after 2, I will fill L5 as 1, but let's see what the answer is. Yes, L5 as 1. Okay. All right, so a couple of quick diseases related to spinal cord. I didn't see any questions related to it, but I thought I'll just briefly refresh your mind. Motor neuron diseases are the diseases that affects the anterior horn of the spinal cord. The more quintessential motor neuron disease is ALS, amyotrophic lateral sclerosis, when these have no sensory involvement because it's motor nerves only. It actually involves the cell bodies of motor nerve in the anterior horn. So you get atrophy, you get fasciculation. The atrophy in the ALS is both of bulbar muscles, so tongue, jaw, chin, face, and also of the arms and legs. And you're seeing atrophy hollowing here. You see some atrophy here, some atrophy in between fingers. You're seeing atrophy of the tongue here. You're seeing the atrophy of the scapular and shoulder muscles and of the arm and upper chest muscles. So ALS is a mixed upper and lower motor disease. So it's different than other motor neuron disorders because not only motor neurons are involved, it also involves specifically corticospinal tract in the spinal cord, not in the brain. It's a spinal cord disease, but in the spinal cord, it will involve the corticospinal tract. And when the corticospinal tract is damaged, it looks like stroke to the rest of the body, and you get hyperreflexia, and you can get the spasticity that you would expect from upper motor neuron lesion. So when you see mixed upper and lower motor neuron feature, then with predominant lower motor, that is typically ALS. Now it can have some variation, and here are some of the variation. You can have something that is predominantly lower motor. You can have, which is called progressive muscular atrophy, has no upper motor features. Typically, here is an example of a predominantly muscular atrophy. There's just motor neuron, there is just no upper motor involvement. You don't see spasticity or hyperreflexia. There could be predominantly upper motor disease, a primary lateral sclerosis, where there is not much of a muscular atrophy, and you see more of hyperreflexia, brisk reflexes, and a stroke-like presentation, Babinski and everything. You can have predominantly bulbar disease. It usually spreads later on, so it's called bulbar onset, but it may remain bulbar for a long time, where the primary presentation is dysphagia, tongue weakness, problem with speaking, dysarthria, and these patients often can be confused with something like myasthenia gravis. They are often seen by GI doctors for a year or two because of dysphagia symptoms before being referred to a neurologist. You can have also pseudo-polyneurotic ALS, ALS that looks like neuropathy, or hemiplegic ALS, and so on and so forth, or monolimb ALS, but those are more for experts. So here's a bulbar one, predominantly jaw, throat, and tongue atrophy. And here is a primary sclerosis where you're getting a spastic hand. The hand looks like the patient had a stroke, but it's not a stroke. It's a spinal cord disease, primary lateral sclerosis. Polio, I mentioned briefly, it's a viral illness. It involves the motor neurons. The virus gets picked up by the motor neurons distally, and it travels retrograde in the nerve axon all the way to the motor neuron anterior horn cell, and then destroys the cell. It predominantly involves the lower extremity and can give a very specific kind of a presentation where there is significant weakness of the lower extremity, and that creates this kind of a patient that walks and drags themselves their upper limbs to walk and stand and drag because their upper limbs are usually better than the lower limbs. There are some other diseases. I'll just mention names so that when you hear them, you know where they fall in the presentation. So spinal muscular atrophy, SMA, has been in the news lately because of the gene therapy that is now available for spinal muscular atrophy. Very interesting concept, probably not going to be tested in your exam, so I'm not going to go into it. And then the spinal bulbar muscular atrophy, which is a variation of SMA, a disease that again you will not get. And then let's quickly go through the brain